Good morning, everyone. I'll be asking you to please be turning your videos on so that I can see you as well. Today, we will be talking about personality disorders. Okay. And the learning objectives are the following. We will be able to differentiate what temperament, character, and personality are, explain the psychobiology of temperament, define and illustrate personality disorders. We are to review, and your knowledge on defense mechanisms will come in handy. We will discuss clinical features, epidemiology, course, and prognosis of personality disorders, and expound on the management approaches to personality disorders. Okay, so I'm going to ask a volunteer. Okay, I'm going to ask a volunteer from you. Okay, sorry, just give me a moment. Yeah, hold on. I'm going to ask a volunteer from you. Okay. Okay. Wait, I'm having some challenges with my there. Okay. Okay. Wait, hold on. Sorry about this technical glitch. There are already 251 of you in the room. Hold on. Okay. So asking a volunteer from you, someone to kindly be reading through the questions. I see future Dr. Paulo Fabro smiling. So Miss, may you please read through the questions?
Yes po, Doc. Do you suspect that others are exploiting, harming, or deceiving you? And do you persistently bear grudges and not forget insults or injuries? Do you almost always choose solitary activities? Then, do you feel indifferent to praise or criticism of others? Then, do you experience recurrent strange daydreams or fantasies?
Okay, thank you. And next volunteer, someone please be reading the set of questions. Thank you, future Dr. Fabros, and someone else volunteering to read through the questions. I'm going to call someone who's smiling, Dr. Mol Pelayo.
Good morning po, Doc.
Good morning. Go on, please be reading this set of questions. Oh, your audio is off.
Sorry po, Doc.
Okay.
First question is, do you experience magical thinking that influences your behavior? Do you repeatedly get into conflicts with the law? Before age 18, have you been cruel to people or animals? Do you have a pattern of unstable and intense relationships with others? Do you have continuous feelings of emptiness?
Okay. Thank you very much. And let me ask another happy volunteer. Volunteers will be rewarded. Good to see someone else smiling. Hindi na mag-smile, ano? In order not to be called. Okay. Yeah. Any volunteer, kindly raise your hands to read through the set of questions. Yes, Cyrus Lee.
Good morning, Doc. Good morning,
Good
everyone.
morning.
So, do you feel uncomfortable in situations where you are not at the center of attention? Are you easily influenced by others, or are you suggestible? Are you generally envious of other people? Are you preoccupied with unlimited success or ideal love? Are you unwilling to get involved with people unless you are certain of being liked? And do you view yourself as socially inept, personally unappealing, or inferior to others?
Okay. Thank you very much. And the last set of questions, the next volunteer, please. Yes, Nicole Verdilio. Go ahead.
Okay. So, do you have difficulty making everyday decisions without an excessive amount of advice and reassurance from others? Are you preoccupied with fears of being left to take care of yourself? Are you preoccupied with details, rules, lists, order, organization, or schedules? Are you such a perfectionist that it interferes with your work?
Okay. So thank you very much for reading through the questions. And if any of your answer is yes, or anyone that comes to mind and you think that's yes for an answer, then we may have to be considering any one of these personality disorders. Okay. Now, we have to differentiate these three concepts: temperament, character, and personality. Temperament is something that is innate. It can be said that it has genetic or constitutional elements and is an inherited disposition. Okay. Whereas character, these are a person's distinctive qualities formed by experience and socialization. Okay. So we can think of temperament as nature and character as nurture. And when we combine nature plus nurture, we get to have the outcome of personality. So it's a blend of both temperament and characterological factors. Okay, I'm losing here a header. We are to talk about the psychobiology of temperament. Okay, now temperament, again, are heritable trait differences, and it was a work of Dr. Cloninger, who looked into these dimensions: novelty seeking, harm avoidance, reward dependence, and persistence. Okay. These are said to be the dimensions of temperament that underlies a person's automatic response to danger, novelty, social approval, and intermittent reward. Okay. So a person who is novelty seeking refers to the tendency to seek new and exciting experiences. It can be associated with exploration as well as impulsivity. So come to think of a person who frequently switches jobs or hobbies or is eager to try something new. Now, harm avoidance is a tendency to avoid punishment by inhibitory behavior, usually associated with anxiety and fear of uncertainty. So come to think of a person avoiding public speaking due to the fear of being ridiculed. Reward dependence refers to the tendency to main behaviors that are attached to social rewards and approval, again associated with sociability and dependence on others for positive feedback. So just come to recall of people who frequently seek approval from their friends and peers. And the last dimension is persistence. This is a tendency to maintain behavior despite frustration, so associated with perseverance and determination. So this is a person who continues to work on a project despite multiple failures. These temperaments are associated with basic emotions. Novelty seeking is associated with anger, harm avoidance to fear, reward dependence on attachment, and persistence on ambition. And this is according to Dr. Cloninger. Yeah. So again, please remember that these are correlated with these emotions. Okay. The dimensions are associated with principal neuromodulators, harm avoidance associated with serotonin and GABA, and you have learned this from when you were in pharmacology as well as your lecture on pharmacotherapy this year. Novelty seeking is associated with dopamine. Reward dependence is modulated by norepinephrine, and persistence, that of glutamate and serotonin. We can come to think of the dimensions as having high and low variance. So if one is said to be high in novelty seeking, we're just going to focus on one dimension. If a person scores high on this and they have developed instruments to score, okay, if there is high novelty seeking, the person can be described as exploratory or impulsive, extravagant, and irritable. And if the person is low on novelty seeking, then that person will more likely be reserved, rigid, frugal, and stoical. And I leave you to just be looking at the rest of the descriptors of the extreme variance of these dimensions. Okay? So, returning to personality and moving on to personality disorders, personality is both an observable behavior as well as subjective inner experience of the patient. Personality disorders have onset in the adolescence and in early adulthood, stable throughout time. It has an enduring subjective experience for the person and others as well. It deviates from cultural standards, rigidly pervasive, and it leads to impairment and unhappiness. So, these are the two words associated with personality disorders. First word is alloplastic. It means that the person adapts by altering the external environment rather than the self. And personality disorders are also egosyntonic. It means that it is acceptable to the ego of the person how she or he is, creates no distress for them, and they do not feel anxiety about their maladaptive behavior. It's the people around them that gets to be distressed because of their rigidly patterns of behavior. Okay? Now, personality disorders are classified into 3 clusters according to DSM-5. You have the first cluster, we refer to them as the odd or eccentric group. In this cluster belongs 3 disorders, the paranoid, schizoid, and schizotypal. Cluster B can be thought of as the dramatic, overly emotional, or erratic personality disorders. And these belong to cluster B, borderline, antisocial, histrionic, or narcissistic. And cluster C are the anxious or fearful group, where the dependent, avoidant, and obsessive compulsive disorders belong. I have a mnemonic for this when I was a medical student. And would you like to know my mnemonic? For cluster A, it's PASS, PSS. For cluster B, it's BAN. Okay. And for cluster C, well, it can be Oda, it could be Dao, whichever you will prefer. Okay, so let's have a deep dive into the clusters. Cluster A, people with this disorder are generally distrustful of others. They misinterpret others' action. They have odd or idiosyncratic beliefs, and they have the tendency toward social isolation. They will come to the clinic already with the experience or with bearers of hostility, and they are maybe in conflict with others. Okay? Now, cluster B, they can be described as labile, unpredictable, unlikable, and impulsive, and they will present to the clinic because they are in a crisis-related and chaotic situation. For cluster C, we can see them as often timid, perfectionist, and are conflict avoidant. We see them in the clinics because they present with depression or of some bodily or somatic complaints. Okay? Now, what are the etiological factors? There are genetic factors, and this is best evidenced by a study in the US of 15,000 pairs of twin, where they saw concordance for monozygotic twin more than the dizygotic, and the monozygotic twin reared apart were the same as those that were reared together. There were similarities in measures of personality and temperament, occupational and leisure interests, and social attitudes of the twins. Okay. For cluster A, we find them common in biological relatives of patients with schizophrenia and schizotypal personality. Cluster B also has a genetic base associated with these conditions. Cluster C as well, avoidant personality disorders will usually have high anxiety levels. OC traits are more common in monozygotic than dizygotic twins. OCPD shows signs of depression, and we see shortened REM, latency period, and abnormal dexamethasone suppression test. Okay. We come to also consider as part of the biological factors, the hormones. People with impulsivity show a high level of testosterone, 17 estradiol, and estrone. Those with low platelet monoamine oxidase levels are associated with activity and sociability in monkeys. And smooth pursuit eye movements are saccadic or jumpy in persons who are introverted, have low self-esteem, have the tendency to withdraw, and who have schizotypal PD or personality disorders. Now, again, carrying on with the neurotransmitters, those who attempt suicide and are impulsive and are aggressive have low levels of serotonin. If we raise serotonin levels, we reduce depression, impulsivity, rumination, and there's a production of a sense of well-being. If we increase dopamine, we can induce euphoria. Electrophysiological factors include slow wave brain activity when we do EEG for patients who have antisocial and borderline personality disorders. Okay. Now, you have to also make room for psychoanalytic factors. You've come to review this in your lecture on psychotherapy. And you will recall Freud, who said that there is a fixation at one point of psychosocial stage of development. And he was the one who have come to make us understand about people who are oral in character. They have become fixated at the oral stage, and we see them as passive independent when dependence for food is prominent. Okay. Anal character, these are the stubborn, parsimonious, highly conscientious because of struggles of over toilet training in the anal period. This is according to Freud. Now, there's a person also we will come to know of, and he is Wilhelm Reich. He talked about character armor. He said that these are defensive styles from protecting from inner impulses and anxiety in significant relationship. And he talked about a stamp of personality. And he said that these are largely determined by defense mechanisms. And he also talked about internal object relations, meaning patterns of self in relation to others that were internalized during the earlier years of development. Okay? Now, let's go on to talk about each of the personality disorder, starting with paranoid personality. You can look at this picture because this can provide to us how it looks like in terms of the sketch. Okay. Now, asking again for a happy volunteer to please read through the characteristics of a person with paranoid personality disorder. A volunteer, please. I see someone smiling. J. Viter Casimiro, may you please read through the characteristics of a person with paranoid personality disorder?
Okay po, Doc.
Yeah.
For hidden hidden meanings read into others' remarks and actions. Exploitation is expected from others. Attacks on character are perceived. Doubts the loyalty of others. And then fidelity of partner doubted. Unjustified suspicions about others and grudges are held for lengthy periods of time.
Okay. Thank you. This comes with a mnemonic. Okay. It may help you remember. So this is how a person with personality disorder behaves. Okay. Now, epidemiology, we see the 0.5 to 4.4 prevalence. Males are more affected than females, higher in minority groups, in immigrants, and deaf people. And when we come to examine the mental status, we can see them to be wary, shifting eyes, hypervigilant, suspicious, guarded. Their thought content will show prejudice. There might be occasional ideas of reference. They're formal in style and are baffled about the psychiatric consult. Now, the defense mechanism primarily used will be projection. And I am somehow assured that you know already about the defense mechanisms, right? Show of hands. You can recall somehow your lecture on defense mechanisms. Yes? Okay. All right. I see most are nodding. So, paranoid personality disorder may be a harbinger of schizophrenia. And we see here lifelong work and relationship problems. How do we treat? It's always the combination of psychotherapy and pharmacotherapy. So psychotherapy is a treatment of choice with a goal of creating trust via solid working alliance. Now, pharmacotherapy, as with many of the personality disorders, there's little evidence to guide the use. But we can use low-dose novel antipsychotic for psychotic symptoms or anticonvulsant for irritability. Okay? So that's paranoid personality disorder, the P in the mnemonic PASS. We move on to schizoid personality. Okay? Now, come to see this drawing of a person with schizoid personality. And I'll be asking someone again, a happy volunteer, to read through the mnemonic of a person with schizoid personality disorder. Nakasmile ulit. Okay, so Kent Acuna, can you please be helping read?
Okay po. For a patient with a schizoid personality disorder. They lead with a solitary lifestyle. They are indifferent to praise and criticism. Relationships of little or no interest. Sexual experiences are not of interest, and activities preferred are almost always solitary. Friendships are few and they are emotionally cold and detached.
Okay.
So the mnemonic is Cersei.
All right. Thank you very much. And the epidemiology, it may affect 3.1 to 4.9% of the general population. There are more males affected with schizoid personality disorder. And in the clinics, you may see them fidgety with poor eye contact. Their affect is constricted. They have monotonous speech. They may be goal directed when they talk to you, but they provide, they what they say lack details. They have one word and sparse answers. They may be fascinated with inanimate objects or metaphysical constructs. And there's an unwarranted sense of intimacy with a person they do not know well or have not seen for a long time. Okay. So the defense mechanism used is schizoid fantasy, course and prognosis. We can see onset in early childhood or adolescence. There's an unknown portion who will incur schizophrenia. Complications may include very brief reactive psychosis because of stress. For treatment, psychotherapy, similar to paranoid personality disorder. How about medication? We can give small doses of antipsychotic, antidepressant, or psychostimulants when necessary. When serotonergic agents are given, they become less sensitive to rejection. And when given benzodiazepine, as we expect, it helps diminish their anxiety. So we will be moving on to the last part. The last group of the cluster A, which is schizotypal personality, and have a moment to look at this sketch. Okay? So again, a happy volunteer to read through the characteristics of one with schizotypal personality disorder. If someone raises their hand, nalobat pa yata kayo. Many videos are off. Please have your videos on. I'll be asking someone who's smiling in her picture, future Dr. Pearl Carbonell. Miss Pearl Carbonell? Are you present?
Yes po. Yes po.
Okay.
Yes po, Doc.
May you help us read?
So for schizotypal personality disorder, so unusual perceptions or bodily illusions, friendless except for family members, odd beliefs, thinking, speech. A for affect is inappropriate or constricted. I ideas of reference. D for doubts others or suspicious and paranoid. E for eccentric appearance and behavior, reluctant in social situation.
Okay. So thank you, Pearl, for reading through the schizotypal characteristics. The epidemiology, there's 3.9 to 4.6 of the general population, unknown sex ratio, but it may be frequent in females with Fragile X syndrome. There's greater association with biological relatives of patients with schizophrenia and higher incidence in monozygotic twins versus dizygotic. When you see them in the clinics or maybe even in the ward, they may have a peculiar appearance. They have amulets, charms, and odd jewelry. Their dress will not reflect social convention or current styles. Their speech may be vague, circumstantial, metaphorical, stereotype, elaborate. The thought content will be expressing magical thinking, telepathy, premonition, sixth sense, out of body experiences, and bizarre coincidence, says as well as ESP. Okay? Now, the defense mechanisms used are the primitive ones of distortion, denial, and fantasy. What happens to them? This can be a premorbid of personality. This can be a premorbid personality of schizophrenia. It may have transient psychotic episodes because of stress, and Thomas McGlashan's study said that 10% of them may commit suicide. So again, a combination of psychotherapy and pharmacotherapy. Psychotherapy focuses on support and being non-judgmental. For pharmacotherapy, we can give antipsychotic for ideas of reference and illusions, and antidepressant for depressive component. Okay, so that is cluster A. Okay, paranoid, schizotypal, and schizoid. Now we're moving on to cluster B and have a look at this image of a person with borderline personality disorder. Okay? All right. Now, asking someone to read through the characteristics of a person with borderline PD. Yes, Kyle Santos.
So for borderline, we have I for identity disturbance, lack of consistent sense of identity. R for relationships are unstable. A for abandonment is frantically avoided. I for impulsivity. S for suicidal gestures are made. E for emptiness is a description of the inner selves. D for dissociative symptoms. A for affective instability. P for paranoid ideations. A for anger poorly controlled. I for idealization of others, followed by de-evaluation. And N for negativistic, undermine their efforts and those of others.
Okay. Thank you, Kaya. So the epidemiology will be 2% of the general population. More females are affected. There's increased prevalence of major disorder, antisocial, so that could be comorbid, alcohol use and substance use in first-degree relatives. In the clinics or the wards, you may see them with scars from slashing. They may have intense and labile mood, argumentative. They could be depressed and then complain of having no feelings, from seductive to outbursts of emotion. They could be very spontaneous about elaborating on interpersonal difficulties. They have themes of idealization as well as devaluation. So one time you're all good, the other time you're all bad. There will be obvious contradictions. They may have perceptual disturbances during micropsychotic episodes. These are defense mechanisms used splitting and projective identification. The course and prognosis are variable, but we see a pattern of chronic instability in early adulthood with severe episodes of affective and impulsive discontrol. They're impaired, high risk of suicide, especially in the young adult. But this is a good thing that it hopefully will gradually wane with advancing age. And in the fourth and fifth decades, some tend to attain greater stability in their relationships and functioning. But the complications may include, again, psychotic-like episodes, premature death, or physical handicaps. What talk therapy may we be able to provide people with borderline personality disorders? We have more now than before. Okay, so first is dialectical behavior therapy, which has received the most empirical evidence. So the goal is to improve interpersonal skills and decrease self-destructive behavior. Now we also have mentalization-based therapy, pioneered by Peter Fonagy from the UK. It aims to help a person's awareness of mental processes and subjective states that come about in their interpersonal interactions. And also transference-focused psychotherapy which relies on two major processes of clarification and confrontation. Okay. Now, these are reminders for providing psychotherapy in a person with borderline personality. Okay. I leave you all to be reading on this. Okay. Now, what about pharmacotherapy? We can give an antipsychotic to help control anger, hostility, and brief psychotic episodes. It will be very hard to engage them in psychotherapy if these are not well controlled. We can also give antidepressant for depressed mood. Benzodiazepine will have to be avoided due to the risk of abuse. And anticonvulsants and SSRIs may improve functioning for some. Okay, so that's the first in cluster B, borderline, and we're moving on to antisocial personality. And again, have a look at this sketch. Okay? So a happy volunteer to read through the mnemonic of a person with antisocial PD. No volunteers. I'll be calling someone who's reading intently through it. Miss Arianthi Renee Ko.
Good morning to the
Yeah. Good morning. Please help read.
For antisocial personality disorder, we conducted disorder before age 15, and then the current age should be at least 18. Antisocial activities and commits acts that are grounds for arrest, lies frequently, um, lacks super ego, obligations are not honored, or there's financial occupational. They're unstable or they can't plan ahead. The safety of the self and others is ignored. Their money, spouse, and children are not supported. They're aggressive and assaultive, and they are not occurring during schizophrenia or mania.
Okay. Thank you very much. Okay. This helps you get reminded about what you've previously learned on superego, right? The id and ego and superego. So they have a lacune. Lacune means like butas, right? So lacks a superego. The epidemiology, 3% in males and 1% in females. There will be a conduct disorder, just like this previously read, before age 10, and some of them may have ADHD. When you have this, it increases the likelihood of antisocial personality disorder. And a child with conduct disorder can progress to antisocial personality disorder if there is erratic parenting, there's neglect, or inconsistent parental discipline. They would often seem to be normal and can even be charming and ingratiating in when you see and talk to them, but they have very disordered lives represented by con men. They can be promiscuous, they abuse their spouses and children. They can be involved in drunk driving. These are common events in their lives. Okay? The defense mechanisms of controlling and acting out are seen in this group. It has a remitting course. Usually, the height of the antisocial behavior comes during late adolescence, and these are the comorbidities. Prognosis can vary. Okay, how do we treat? Again, a combination of psychotherapy and pharmacotherapy, but for psychotherapy, there's limited evidence that suggests they respond better to contingency management. And I hope you have learned about this in your lecture on psychotherapy. And so other reward-based interventions, they do better on this rather than on cognitive behavior therapy. For pharmacotherapy, it's targeted for symptom relief. So we use these pharmacotherapeutic agents when they have intense anxiety or rage and depression. Anticonvulsants can be given to treat aggressive behaviors, especially if there are abnormal waveforms on EEG. And there's a significant portion of people with antisocial personality who may have, as children, when EEG all done, they would have these abnormal waveforms on EEG, signifying what is known to be before as minimal brain dysfunction. Okay. Beta adrenergic receptor antagonists, lithium, and antipsychotics may also be given to help reduce aggression. Okay. So for cluster B, we're done with borderline, antisocial. We're moving on now to histrionic personality. And please come to look at this sketch. Okay. Sino pa ba? Oh, dito si Papa Freud. Okay, so someone to be, again, happily volunteering to read through the mnemonics of someone with histrionic personality disorder. I see someone nodding. Ivane, Yara. May you help read the mnemonics? Yara? Can you hear me? Ivane, Isabel, Yara, can you hear me? I see you nodding. Am I pronouncing it right? Ivane, Isabel, Yara. Can you please help read?
Yung histrionic personality disorder, inappropriate behavior, seductive or provocative, center of attention, relationships are seen as closer than they really are, appearance is most important, vulnerable to suggestions of others, emotional expression is exaggerated, shifting, swallow emotions, impressionistic manner of speaking which lacks detail, novel situations are sought.
Okay, thank you. That should have been shallow emotions, okay? Thank you very much. And the epidemiology, as we see in the screen, 2 to 3% prevalence. They're more frequent in females and males and associated with somatization and alcohol use disorder. Defense mechanism used may be dissociation. Of course, in prognosis, they're usually seen as sensation seekers. They may get into trouble with the law. They abuse substances and again act promiscuously. Combination of psychotherapy, which is psychoanalytically oriented, wherein inner feelings are clarified. Pharmacotherapy, again, targeted symptom, adjunctive to psychotherapy, antidepressant for depression and somatic complaints, anti-anxiety, antipsychotic for derealization and illusion. Okay. Now, the last for cluster B, narcissistic personality disorder, come to look at the image and someone please be reading the clinical features. Mr. Alfred Opetina, may you please help read? Mr. Alfred Opetina, may you please help read? Can you hear me? Mr. Alfred Opetina. Mr. Alfred, can you hear me? Hello? Are you there? Are you with us, Miss Alfred Opetina? Someone be signaling him. Hello? Are you hearing him call? Are you hearing me call him? Am I still heard? Okay. Miss Daniela Pataho, please help read.
Morning po, Doc. So, narcissistic personality disorder, admiration is required in excessive amounts, fantasizes about unlimited success, brilliance, beauty, and ideal love, arrogant, manipulative, envious of others, or believes others are envious of him, grandiose sense of self-importance, associates with special people, me first attitude, empathy lacking for others.
Okay. Thank you very much. And we see here the epidemiology, defense mechanisms, and the course and prognosis. Okay. Again, a combination of psychotherapy and pharmacotherapy, but there still is need for more research to determine best treatment. Some advocate for psychoanalytic approach and group therapy. We can give lithium if there are mood swings and antidepressants and serotonergic agents for depression. So we're winding down to the last cluster, which is cluster C. And take a look at the sketch of a person with dependent personality. Okay. Now I'm going to ask again, Mr. Casimiro, may you please help read?
So needy. As others assume responsibility for major areas of life, expression of disagreement with others is limited, excessive need for nurturance and support, decision making is difficult, self motivation is lacking, preoccupied with fears of being left to care for self, urgently seeks another relationship when a close one ends, self confidence lacking, and helpless when alone.
Okay, thank you very much. And kindly read through the epidemiology. And please keep in mind that chronic illness in childhood or those with separation anxiety are most prone to develop dependent personality disorder. These are the defense mechanisms used by people in this group. Okay. And this is a course and prognosis as well. Very favorable prognosis if given treatment. So treatment will include psychotherapy, where we provide the kind which is called insight-oriented so that they can understand the antecedents of their behavior, become more independent, assertive, and self-reliant. There are also other interventions, behavioral assertiveness training, family and group therapy with some successful outcomes. Again, it's symptom-targeted therapy. We may give benzodiazepine and serotonergic agents. Okay. The next in the cluster C will be avoidant. And I'm going to ask Mr. Fabros to please read through the characteristics.
Okay. Avoidant personality disorders. A, avoids activities. U, unwilling to get involved. R, restrained within relationships. I, inhibited in new interpersonal situations. C, criticism is expected when in social situations. L, lower than others self-view. Then E, embarrassment is feared emotion.
Okay, thank you very much. And this is the epidemiology. The main central clinical feature is hypersensitivity to rejection of others, and the major personality trait is timidity. Okay. Defense mechanisms, inhibition. We see avoidant personality emerging already in childhood as possible shyness and fear of strangers and new situations. They can be functional in a protective environment. And should their support system fail, they're prone to depression, anxiety, and anger, and phobic avoidance may be common. Combination of psychotherapy and pharmacotherapy as well. Okay. Now, lastly, the obsessive compulsive personality, and please take a look at this image. Someone please be helping read the mnemonics. Miss Mejia, may you please help read?
So for obsessive compulsive personality disorder,
Yung mnemonic ay perfection. So for P, preoccupied with details, rules, plans, organization. Emotionally restricted, reluctant to delegate tasks. Frugal, excessively devoted to work. Controls others, task completion hampered by perfectionism. Inflexible, intolerant, overconscientious about morals, ethics, values, and lastly, not able to discard belongings.
Okay, thank you. Please hold in mind that OCPD is different from OCD. Okay, OCPD is different from OCD. So these are the epidemiologic features, defense mechanism, and course and prognosis. Treatment combination of psychotherapy, but there's still limited studies. Cognitive or CBT and interpersonal therapy can be provided for depression. Again, limited evidence what we can give, but serotonergic agents can be given in situations of depression or anxiety. Okay. Now, one's personality can change because of another medical condition. And these are the medical conditions that can change a person's personality. Okay. Yeah. So please just come to read on this. But the most common one will be a trauma to the brain or a traumatic brain injury. Okay. Now, we're winding down. This is going to be the last one of the last few slides. And have a look and see if this were to be a parking lot of the personality disorder. So what do you think? What personality disorder will represent the one who parked here, number one? Okay, just to have a jump start. A person possibly with paranoid personality disorder who feels that he has been cornered again. Okay? What about the person who parked in number two? What do you think? Compare it with the rest of the cars. Compare it with the rest of the cars, it could be, Mr. Frabos is to say,
Doc, narcissist po.
you're
Possible.
right, narcissist with the largest car and a very prominent hood ornament. Thank you very much. What about for number three? Any guess? Someone in the chat box? Yeah, can't. It's, let's see, it's dependent, needs another car to feel sheltered. Okay, we'll move on to number four. This we may not have discussed, has been previously described by other literature but not included in DSM-5. Well, colorful histrionic, yes, that could be one of those considerations. And let's see, it's actually passive aggressive. Angles, hindi to angels, angles the car to take two spaces. Okay, but that's also a consideration, histrionic. Okay, but let's see the rest. Okay, thank you very much for your guess. And shall we proceed with number five? Oh, sorry, I gave it away. Borderline, rams into the car of an ex-lover. Okay. Number six will be, any guess? It's antisocial, blocks others' cars. Number seven, this was your previous guess, histrionic, parks in the center of the lot for dramatic effect. Number eight, obsessive, perfect alignment in parking space. Number nine, avoidant, hides in one corner of the parking lot. Number 10, schizoid, can't tolerate closeness to other cars. And lastly, number 11 will be schizotypal for intergalactic parking. So these are my references, and thank you for your participation. I hope after this lecture, you have one of these more positive states. So we'll be ending this session. I've taken a screenshot. Is that okay? Yes, evidence that we had this lecture, and yeah, goodbye for now. We won't have time for questions, but if there are some questions, of course, you can give us your questions through the. Oh, yeah, my reminder. Please don't forget to evaluate today's lecture. Okay? So we'll be dismissing now. Get ready for your next lecture. Okay? Bye.